symposium agenda, I assume you all have your packets. We'll start, I'll be giving an introduction and overview of the Rome Foundation and the Rome 4 process. And then we'll have the working team reports, which will be moderated by Robin Spiller. We'll have a brief break, and then we'll go into the support committee reports, then the sponsor presentations, and then at the end we'll have an open forum for discussion. I think it's remarkable to have so many pharmaceutical companies together, working together, and I look forward to how the meeting goes. So let me just tell you something, and I apologize to the Rome 4 members, because it's the same, pretty much the same talk I gave yesterday, but by necessity we have to do it for the sponsors. Our mission is to improve the lives of people with functional GI disorders. The focus is on the people with functional GI disorders. We do this in 3 ways: to promote the recognition and legitimization of the field, to develop a scientific understanding of their pathophysiological mechanisms, and to optimize clinical management. This is probably the busiest slide we have. Just to give you an idea of what the Rome Foundation has done, we developed the first classification system in 1990. We established the research utility and legitimized IBS and functional GI disorders to clinicians. If you go back, in many ways, disorders that were of a functional GI nature were not valued as much. We promote a biopsychosocial model, meaning that we're looking at the integration of mind-gut interactions in research and patient care. We did develop and validated the questionnaires to identify research populations, and in 1993, 20 years ago, we published the first national epidemiologic study, and what you'll hear is that we're now involved in global evaluation. By Rome 2, these criteria were adapted by pharmaceuticals and regulatory agencies, so if you're doing a study in IBS or constipation or dyspepsia, often this is going to be the inclusion criteria. What you see here and what happens at our advisory board is we have a forum for interaction among industry and regulatory agencies. And this involves the Japanese regulatory agency, who I believe is here today, the EMA, and the FDA. We started in the last few years with Rome 3 to start translating questionnaires, and so we have become a global presence, as I'll show you, and we'll be moving forward with further translations with Rome 4, hopefully concurrent with the Rome 4 publication. We established annual research awards, and we will now begin to increment them, and we have international symposia. The organization is a nonprofit international organization, 501c3. It has a president and board. The members are selected similar to the National Academy or the Institute of Medicine, that the board will determine areas of need or interest or value, and then we select people based on a criterion system. We have an advisory council that includes industry, regulatory, NIH, and IFFGD. We do have an associates program where people can join, and we're currently over 500. We have our system of committees and working teams, and we have our administrative staff. Go on to the next slide. This is the board is shown up here. We have an administration group. The liaison committee, which I'll show you, involves our global outreach, public relations, and support services, which will be the web, the book, and so on. And then our committee structure is down here. There are 6 support committees that you'll hear from, 5 working teams, the clinical algorithms committee, which is going to be revised, and the Rome 4 committees, which was launched yesterday at our orientation, as well as 19 full pharmaceutical sponsors. This is our administrative staff, just so that you'll recognize them. Wink Hilliard is our executive director. Cecile Rooker is director of marketing. Michelle is our administrator, who handles the scientific committee work. Claudia Rojas has just come on about 6 months ago and is our Latino representative who will be involved in the booth and other Latin American programs, and then we have our website tech design. We have a very effective medical illustrator, which you'll see the product in the next few years, and we have a trade show monitor. Now, Nick Sartorius, who is the president of WHO, wrote about the ICD-10 that was about to start. He said, "A classification is a way of seeing the world at a point in time. There is no doubt that scientific progress and experience with the use of these guidelines will ultimately require their revision and update." And I think this is an important point. When Rome first started coming out, there was a lot of anxiety that things were going to be etched in stone, and it won't change, and it would stall progress. Well, I think it couldn't be further from the truth, because what the whole process is one is evaluation and modification if needed. If criteria are going to change, the idea is to maintain the criteria, but if there is clear evidence that a criteria needs to change, that has to be provided before it's accepted and occurs. This is just the rationale for symptom criteria, and you have to understand when the Rome the Rome working team started 20 years ago, the concept was we need to find a better research instrument or physiologic instrument to define these conditions. But as we learned that that's one part of a larger picture, which is the symptoms that patients bring to us. Symptoms are defined by multiple factors as things have evolved over the 20 years. And so by having a symptom-based diagnosis, you have the ability to identify groups and to understand their physiologic determinants. Most importantly, symptoms are what patients bring to doctors. Patients don't bring to doctors that they have a physiologic disturbance or a biochemical abnormality. There is epidemiologic support that has bred true, the strongest being IBS in terms of its 3 symptoms based on factor analysis, population studies, and clinical studies. And this obviously has treatment implications. And what I'll show you later is that as we start to look at profiling these patients in the sense of looking at the dimensionality of their illness, not just whether they have a diagnosis or not, we can have very valuable treatment implications. And this provides diagnostic standards. It was actually modeled after the psychiatric classification. And this is helpful, as you know, for clinical trials and clinical care. The limitations or qualifications is that the criteria are not fully evidence-based. We really began this process by a Delphi approach when there was no science to define these conditions. We brought experts together from around the world. But as time has gone on, what we've done is we've incorporated the evidence. Now, one of the things we don't do is that we don't rely on evidence-based data. Let me put it this way. We don't rely on meta-analyses to define clinical meaning. We use a combination of looking at the evidence and then looking at that in the proper clinical context by people who've worked in this area. And any changes that we're doing are going to need validation. We also recognize that the criteria done for research are not sufficient for clinical practice. We can subgroup patients into categories and look at physiologic features, but that needs to be translated into clinical management. We recognize the fact, and there's been some recent concern, that do we need to have these anatomic distinctions? Are there similarities in what goes on in the midgut and the anorectal area or the upper, the dyspeptic area? And so we're trying to look at ways to undertake that for Rome 4 and to develop some clearer ideas of distinctions that are clinically relevant. So we need to identify meaningful subgroups, diagnostic groups. We want groups based on physiologic features that might be targeted, for example, to a particular drug. We want to look at biomarkers, and we will modify the criteria to fit new knowledge. The concept of the biopsychosocial model is really nothing new. It's just that there is a brain-gut axis. There are certain patients who might have only physiologic disturbances, but when you get, for example, into chronic painful conditions, you have interaction between this, and there's brain imaging to support that, and we'll be moving into demonstrating that in the papers. Not to mention that there could be genetic polymorphisms or environmental factors which can amplify or modify this, leading to the clinical outcomes that we see. How have we done? Rome 1 began around here. The articles started in 90 to 93, and the Rome 1 book was here, and Rome 2 came out about here, and then Rome 3 came out here, and you can see there's an incremental rise, primarily where they're using these, the criteria. And this is about 1/6 of the articles that have been published on, for example, irritable bowel syndrome. We don't want to take credit, but we value our participation in the rise in research going on in these areas. We really began around 1988 with the first committee in Rome, and if you're wondering why it's called the Rome Foundation, it's because Aldo Torsoli and also Enrico Carazziari, who's here, really had the idea of setting up working teams which were committees to solve clinical problems that did not have the evidence. And so the Delphi method began here. The first one was, first author was Grant Thompson, who did the paper on diagnostic criteria for IBS. That then moved into 1990 when a full classification occurred, and then the rest is history, beginning with the Rome 1 book, the Rome 2 book, and then there was a supplement in gut. Rome 3 was in 2006, and then a supplement in gastroenterology. And then we've also developed a primary care book, clinical algorithms, and a computer-based imaging program. Rome 4 will be scheduled to come out in 2016, fully 10 years after Rome 3. The computer-based learning program will be the basis for images that will be present in the book and online. We do have a website, which is a repository of information. You can pick up the questionnaires for research, the diagnostic criteria, the publications for Rome 3. This was the most recent thing is the communication skills workshop, which is online. If you're interested in working in doctor-patient communications. We have an annual newsletter, and I suspect it'll be out there. Grant Thompson wrote a primary care book, but we're taking this further by having a full committee, as you'll hear, that will be addressing where primary care doctors see these conditions. I want to remind you that every year, this is the 6th year, we have an AGA Institute Rome Foundation lectureship. We try to stay ahead of the game in terms of what's important, and this year it's going to be on the role of food sensitivities and microbiota in functional GI disorders with 2 well-recognized speakers in the area, Kevin Whalen and Sheila Crow, and they'll be speaking on Sunday morning from 8 to 9:30, room 109A. As I mentioned, we did the communication skills workshop. If you're interested, you can see it either at the AGA website where you can get CME credit, or you can go to the Rome Foundation website. One of our new features is the Rome update. So at DDW, we will have an evaluation of the abstracts. This will then be adjudicated by committees to have the top abstracts, and that'll be presented in a video news format. This was what was done last year, and that will be online for CME credit. The clinical algorithms is something we began in 2010, 4 years after the Rome 3 publication, and it came out of the criticism that patients don't come to you with diagnostic criteria. They don't say, I have functional vomiting or irritable bowel syndrome. They come with symptoms. So the algorithms, as you can see, begin with a series of about 15 symptoms, diarrhea, abdominal pain, nausea, vomiting, and so on, and takes you through the diagnostic pathway coming to a diagnosis. So these algorithms, as shown here, we use standard decision-making. We have a case report and annotated references with each algorithm, and then this leads to precise final diagnosis. So it's a diagnostic tool that could be helpful for primary care doctors, medical students, healthcare extenders, and the like. And it may reduce clinical costs by making an effort not to overdo diagnostic studies. We now have translations in 4 languages, and that's going to be one of our features for Rome 4, is that these algorithms will be updated and available in the chapters. I do want to thank our pharmaceutical sponsors. Anyone who's here has a star next to their name. That means that you're going to be hopefully involved with the evaluation of the documents and providing feedback. We have a total of 19 full sponsors, 20 pharmaceutical companies. We are engaged in collaborative efforts with the FDA and regulatory agencies. Lynn Chang is the Rome representative on the FDA CPATH committee. We have had involvement with the various regulatory agencies. They participate in the endpoints and outcomes and the IBS Global Conferences, and we're now talking about every 2 years in Milwaukee having something else like that that is involves regulatory aspects. We do work closely with the IFFGD. We have collaborative meetings, as I mentioned, and we have a shared philosophy for patient care. I want to introduce one other new committee that just formed, which is the Rome EMA Pediatric Committee. The EMA came to us asking, can we help them develop guidelines for pediatric functional GI disorders? So we set up a subcommittee with Jan Tak, who's on the Rome board, Jan Tamanow, who's with the EMA in pediatrics, and Miguel Saps, who's in the Child Adolescent Committee, the Rome Committee. And this subcommittee will be interacting with the design of treatment trial, which Brennan Spiegel chairs, and the pediatric child adolescent with Carlo Di Lorenzo chairs, and they'll make recommendations both to the Rome committees as well as to the EMA. And then this will be reviewed by the Committee for Medicinal Products for Human Use of the EMA, and then hopefully there'll be a combined set of recommendations for design of pediatric functional GI disorders. Now, I want to talk a little bit about the global initiative. Is Ami here? Ami Sperber? Okay, you'll be talking more on this, is that right? All right. All right, I'll go quickly. The International Liaison Committee, which Dan Dumitrasco chairs, has been a committee that is an outreach to our global organizations. They consult with the Rome Foundation, they liaise with other organizations. Ami will tell you more about the translation project and the international committees, which we have now several, to try to not only bring the Rome information to these areas, but to learn from them in order to modify our criteria to make it truly integrative cross-cultural recommendations. This is the International Liaison Committee representing the Middle East, Eastern Europe, Western Europe, China, Japan, and Latin America. This committee meets regularly and makes recommendations to us. We've translated the Rome 3 book into 4 languages, and our algorithms also into 4 languages. I imagine that in your packet you might have, if you don't have the algorithms, we can have them available for you. This all began with our 2011 meeting in Milwaukee, and you can go online at the Rome Foundation and see actually hear and see the presentations. One of our newest initiatives is the China Initiative, where the hospital at Beijing set up a wing for teaching. It's a combined Rome Foundation, North American Educational Foundation, to teach functional GI disorders to gastroenterologists in China. I mentioned about the Associates Program. The Associates Program is a way for people to actually join, because the nature of the committee is to select members. This will allow people, as you can see, of a more international nature, of a very international nature, to come in, to have discounts, to be given invitations, and this involves a variety of individuals, and anybody in a medical field, including pharmaceuticals, can be associates. So that's the overview, and I think we have a very busy schedule, so what I'm going to do now is to give you a little bit about Rome 4, and then we'll go into the presentations, so you'll understand what our goals are going to be. The editorial board consists of 5 associate editors, a managing editor, administration, and we have other staff as well involved. We will be publishing the book online and in printed version in 2016, and we're fortunate to have this, like Rome 3, as a special issue of gastroenterology. Now, why do we want to do Rome 4? People always say, why do you keep reinventing? Well, science has changed. If you think about what's happened since 2006, there's much more involvement in the microenvironment, microflora, brain-gut interactions, more recently food and diet. There's constant discussion about the best research study design, endpoints, and outcomes. And we're also talking about new treatment options that didn't exist at that time. We're also feeling that we can move from consensus-based to evidence-based diagnostic and treatment recommendations. We also can, I think, dispel the functional organic dichotomy, the idea of low-grade mucosal immune dysfunction. Some of the work being done in brain imaging is in many ways organifying functional GI disorders, just like there are organic disorders that can be functionalized. You can see the concept of IBD, IBS, and so on. We need to start to look at this within a multinational context, and we've made considerable efforts to bring that information in, and we also need to reach primary care. What's new for Rome 4 is that we're going to, what we've done, right now we're at the midpoint of the process where a series of committees, by design, have prospectively acquired new data to meet the needs of the field, which will then be discussed today at the symposium. We have expanded our chapters into areas that we think are very important to consider. We're updating the algorithms. We're going to have concurrent release of translations, and you'll hear more about that later. Online access, this is going to be an online book. The online book is going to open the door to have virtually unlimited information in terms of images, graphic images, and so on. Now, you might wonder how the committees were selected. We have a set of criteria for the chairs and committee members based on academic accomplishment in their area of illness of an international nature. There has to be some diversity in terms of the institutions and diversity issues as shown here. In terms of discipline, we have a multidisciplinary group of basic scientists, clinical gastroenterologists, epidemiologists, psychologists, psychiatrists, and the like. And we also foster a group working in groups. So the editorial board proposed names to the chairs and co-chairs once they were selected. And there were some conditions, like if a previous chair or co-chair was on it, we wanted them to be on the committee as a member to help with the process. And then we were looking at areas that we think were new or diversity issues. One thing, Rome does have a network of associations of understanding in the countries who are the important people involved in those areas. And then we suggested the members and endorsed them in 2012. So with this collaboration, the chairs and co-chairs actually selected the committee. We made recommendations. They brought it back to us. We endorsed it, and then invitations went out in October. There were a couple of conference calls that were set up, and the meeting was now, and now for the next 2 years, the committees will be developing their chapters. What are some of the challenges we want to address? Well, I think we have to understand the overlap across conditions like PDS and EPS and gastroparesis. Where does bloating and distension fit in with these disorders? Are they really distinct syndromes, or are they so involved with other conditions that they might be important to consider in their evaluation or criteria? The whole concept of IBS-C and constipation and now OIC needs to be thought about primarily by the bowel committee. Then there's the co-association of bowel and pelvic floor conditions. What about pain and discomfort in diagnostic criteria? We've tended to acknowledge that both can be used for criteria. Other companies have shown that there might be distinct differences. What is the physiologic load that is necessary in understanding conditions like functional heartburn? Is it NERD, or do you have to have evidence of lack of pH or impedance? What are the postprandial symptoms? How do they relate to IBS? How do biomarkers fit in? Are there cross-cultural differences? And then what is the role of the CNS on symptom severity and reporting? So this is a variety of challenges we're looking to undertake. The support committees, there are a series of committees, as I've mentioned, that are in place now. You will hear from these committees, questionnaire and validation. Systematic review is the committee that's going to be providing the evidence for the committees and meta-analyses. Primary care, you'll be hearing about that today in terms of two roles. One is, how do primary care doctors understand these disorders? And then secondly, how would we, quotes, translate this to an area of relevancy for primary care? This will be a publication and then later a book for primary care. Some of you may have heard this already, but we are looking to develop guidelines to subset patients into clinically meaningful groups. And the way to think about this is that the Rome criteria is a categorical diagnosis. You either have it or you don't. What we're looking to do is to add dimensionality to that so that we can look at essentially the continuum of patients with a condition, say irritable bowel or dyspepsia, and look at treatment as it may be affected by those subsets. So we're going to be profiling these patients with modifiers, and then this will be used online in the diagnostic chapters. So here is the profile as it's set up, where the categorical diagnosis is the Rome criteria as it exists now. That will continue to be the same with its same priorities of how it gets published as a criterion. What we then have is a class of clinical modifiers, and this may have relevance for treatment. It definitely does when you look at IBS-C, D, and M. If you look at Rome 3, while everybody talks about IBS-C and IBS-D, it's not in the criteria. It's merely a table that recommends a way of subsetting it. So now, when an individual patient is profiled, they'll have a diagnosis and they'll have a categorization. Is post-infectious etiology going to be something that might involve different treatments than the lifelong history? We also have a patient-designated impact based on a question that can be asked where they can rate it as none, mild, moderate, severe. We know that in the more severe cases of functional bowel with pain, there may be comorbidities that are preventing normal regulatory activities occurring from the brain to the gut. And then there will be severity in physiologic features. Incontinence is an example where there might be so much severity it might require different treatments than if it's milder. The working teams have published the guidelines for brain imaging in 2009, outcomes and endpoints in 2009, guidelines for severity 2011, and the role of intestinal flora 2013. And in addition to that, the food and diet has just come out this month. The food and diet is shown here. There are a series of 5 articles in the American Journal of Gastroenterology, and I believe we may have copies for you. And also we have the, we have the Asian working team, which has been doing surveys to try to understand how people in Asia are reporting these symptoms. There are distinct differences. The role of bloating, for example, is more commonly used in Asia. One of the other important areas is that where endoscopic evaluation is much less expensive and the risk of cancer is higher, there's a distinction in the diagnostic approach where the Asians might more likely test and then treat, whereas we might do treat first. You'll hear more from Ami on the international cross-cultural research. So we will have a chapter structure that includes, for the criteria chapters, of which there are 5, each condition will have a diagnostic entities, definition, epidemiology, the criteria, any justification for change in the criteria, pathophysiology, clinical evaluation. The multidimensional profile, which I just mentioned, will be actually part of the online version and as a separate book, and treatment and recommendations for future research. The content area chapters that are not diagnostic chapters will pretty much maintain the same structure, and there may be new chapter formats that are created. The online features, I want to mention that this is going to really open the area for investigation, for searching the book, because you can download the full book or by selected chapters. It's also available as rental, or online per search. So if a medical student sees a case that he or she wants to evaluate for rounds the next day, they can go online and pay for the search itself. The computer-based learning and algorithms and the images will all be online as well. So you could click on a condition such as dyspepsia, you can then go to the algorithm or look at multidimensional case examples. We also will be bundling this with a printed book. There will be discounts. Actually, any Rome 4 sponsor will have free access to the online publication. So the deliverables, I think we've talked about. There'll be a Rome 4 book. Now it's going to be a 3-volume set, the ebook, and we are working on iPad applications and updating these. They're also going to have a pediatric book and a primary care book. Here's the timetable. I think you've seen this slide before. We are right here in the middle of the process, and then we'll have annual updates for you. In 2015, you will be getting manuscripts, pre-publication for comments from the scientific, the research people in your organizations, and then it'll come out as a journal supplement and book. The quality control, it's a very interesting collaboration we have with sponsors, because we have to have the sponsors yet apart from the process to avoid any perception of undue influence. We have instituted the Institute of Medicine guidelines for interactions with conflict of interest. There is a confidentiality statement, and let me mention, if the sponsors, if you've not had a chance to sign your own confidentiality, if you go out to the front during the break, please sign it, just saying that this information can be contained within your committee but not outside of that or outside of members. There's a peer review process, which is just like any other publication, and there will be an embargo on information until final editing and publication. The last slide is just to show you the benefits of sponsorship. We can skip the special certificate, though you will get one. But you provide feedback and on preliminary manuscripts. You will receive a summary of the meta-analyses done. You will have free access to the questionnaires and criteria. We now have instituted a copyright and licensing policy for studies, which could cost $10,000 to $30,000. As a sponsor, that's waived. And you'll get some bells and whistles. All right, thank you.